I'm asking Councilor Thornton if he'll lead us in the invocation, please.
Dear Heavenly Father, thank you for this day and for this meeting that we're bringing about to try to help our people, our Cherokee people throughout our nation and abroad and federal-wise. Anyway, thank you for this day and appreciate it. God bless you. God bless everyone here today. Amen.
Ms. Shelley, will you call the roll, please?
Yes, ma'am. Janelle Fulbright.
Present.
Dick Lay.
Here.
Jack Baker. Carly Buzzard.
Here.
Joe Bird. Julia Coates.
Here.
Jody Fishinghawk. Don Garvin. Tina Glory Jordan.
Present.
Frankie Hargis.
Present.
Lee Keener. Curtis Snell. Janice Taylor.
Here.
David Thornton.
Here.
Victoria Vesquez. David Walkingstick.
Aye.
Kara Cowan Watts. We do have a quorum.
Thank you. Next is the approval of the minutes.
Second.
We've had a motion and a second to approve the minutes. All in favor of approving the minutes, let it be known by saying aye. Aye. Any opposed? The minutes are approved. Next, we'll go right into reports, and first is Claire Moore, Mrs. George Valyers. We're glad you're here today. We missed you last month.
Well, I apologize. I was out of the country and I had sent somebody down and I forgot to tell them that you moved on, you didn't have it here in November. So that, I tried. I would like to introduce our ambulatory care director, Commander Kelly Batiste. He's been with us for a year now. So you may see him down here if I'm out of pocket at some of the meetings. All our visits are, ambulatory visits are up. Collections are down a little bit. The new services, we've got the Oklahoma State University cardiology bus coming once a week, every Friday. The other new service there, the chiropractic service, is a pilot program started by area office. We have a chiropractor coming once a week. You can call, patients can actually self-refer to that chiropractor at the number listed on your report there. The MRI, the area office has come in and started doing soil samples back in the backside of the hospital where at the site where their MRI is going to be located. So they have actually started some physical work on that. I'm told by the area that their target date for completion and to have it up and running is the end of February, so we'll see. Any questions? Yes, sir.
What are they're gonna put a modular building in?
Yes, sir. It'll be on the east property back behind administration. It'll attach to the where the inpatient rooms are.
I've got a question, if nobody else does. How's the chiropractor working out for us?
He's only been coming a couple of weeks. I haven't had any complaints.
Oh, okay.
I understand he's. I checked the other day, and he had a full schedule. He had 23 patients scheduled last week on his one day.
Wow.
Councilman Buzzard?
Follow-up question.
Our
for
doctors
you.
need to see that.
On the last page here, and I think I've asked you for this before, it said Cherokee, is that the number of Cherokees that got funded, denied, deferred, and health?
Yes.
Power and health centers used? That's the number of Cherokees on those numbers, isn't it?
Yes.
The last one, CIH clinic. Tell me exactly what that means.
Those are referrals, people that have been referred out. Referrals actually hit our contract health system
Okay, from the clinic in your service.
from our hospital, from your clinics. But we actually can provide that service in-house, and so they're referred back to Claymore Indian Healthcare Clinics. So they're referred back in-house.
Okay. I got you.
Counselor Cherokee on what?
Thank you, Madam Chair. Hi, George.
Good morning. Afternoon.
I'm glad you're not bringing up football. Okay, so how's the marshal service arrangements working?
Last time I checked, they are working well. The emergency room brags on them, that they have a very fast response time to all of our suicidal patients.
And anything else?
No
So, okay.
complaints at all.
Very good, thank you. And then on contract health and our arrangements with the Cherokee Nation Contract Health Services, kind of as a follow-up to, I think, what Harley was asking about, Councilman Buzzard. How is that relationship working? It seems to be working well on your numbers, but I'm not clear between what your numbers matching up to their numbers. I don't know if that's what,
Yeah. Percent-wise, I guess, is what the question would be. How many approvals versus how many denials are there?
Oh,
Using the 5%,
as far as what?
as using the contract health dollars for Cherokee
Mm-hmm.
citizens. I'm not sure I'm asking the right question.
I guess, before we get into those details, which I think we can ask Connie about on the 5%.
Okay.
From your perspective, is it working better in terms of from the patient and from your side, if they're being worked with on the 5% and the referral out?
Yes, it's my understanding it's working pretty smooth.
What about for hearing aids, dentures, partials, or prosthetics?
Hearing aids, we have a really large backlog on getting patients into the audiologist. And she's slowly working through that. Dentures, on our side, that's not an issue for us. We want to.
So when a Cherokee citizen comes through the dentist and has their teeth pulled and stuff, do you let them know that Cherokee Nation has the ability to do dentures for them? Have
I
we
don't-
provided paperwork to you?
I don't know that on the dental side, I don't know that that's ever come up because everybody knows we don't provide that, so that's not an issue with us. Now, I don't know if we have any literature or anything to send down and refer them down to you guys. And we can do that. That's not a problem.
So you're open to it, and I'll save the remainder of that question for Connie then.
Sure.
What about prosthetics and stuff? Are we addressing those issues? Would that go through contract health or somewhere else?
We won't go through it at all. It's called a durable medical device, and it won't be paid through contract health.
See, under a 5% set aside, we provide for prosthetics, so we're not educating our Cherokee citizens either that are served by Claremore Indian Hospital. That's an option.
Mm-hmm. Yes, it is.
You do educate them?
No,
or-
no,
Okay.
that's an option.
I'll
So
save the rest.
I'm
of
not
it.
actually sure what's actually provided in the 5%. I refer Cherokee Nation citizens or Cherokees to Brett. I refer them whenever there's a question about when they're denied with us or what we don't have.
Okay.
Or what you guys do provide, I refer them all to Brett.
Okay, very good. I just have a couple more questions. What's your current staffing level? How many staff do you have total? Is it 400 and something, 450?
Yeah, something like that.
And then approximately 450, and then is active still over?
It's over 100,000.
And then it says collections are down, but I didn't understand why. I guess I missed a meeting.
We're looking at some trends and trying to figure out why, because Medicaid is actually the part that's down. So we're trying to figure out exactly why that's down.
Are you gonna let the board, the Indian Hospital Board know, or can you provide that maybe next month or something? Okay, thank you so much. Thank you for your time, George.
You're welcome.
Any other
Thank you, Madam
Councilman
Chairwoman.
And I don't, well, maybe you can tell me to that. I've always watched, or I've looked at the occupancy rate there at Claremore. Why is it so low? Is it, we just don't have the doctors to perform some of the things that need to be done? And how many, and the other question, how many beds do you have there? I don't really know.
We're actually, through Joint Commission, we have 46 beds.
Okay.
And the other question is, we've got to get our docs to accept those patients and put them in the hospital. And I think what's happened is we get a challenging patient. Well, instead of putting them in our hospital and actually practicing medicine, it's easier just to transfer them to Tulsa. We're going through a process right now to where we're re-examining all those transfers. And looking for those that we can keep in-house, should have been kept in-house to educate those docs as to what we can and cannot do inside, because most of our ER docs, in fact, all of our ER docs are contractors right now.
And I kind of thought that might have been some of the problems, because maybe we didn't have the experienced staff there to
Yes, sir.
be careful. Yeah. Can that be addressed as far as, like, you get your hands are tied as
Well,
what you can retain there?
we're advertising for internal medicine doctors. And new hospitalists. We have two staff hospitalists. We have one staff internal medicine doc. We're trying to get our own staff doctors so we can get them oriented to the hospital, to the system, to the Indian Health system, and what all we can do there.
Okay, thank you, thank you.
Any other questions? Okay, thank you for that good report.
Thank you.
Next is Ms. Connie Davis.
Good afternoon. If you don't mind, it was requested by Ms. Fulbright that we have the audiologist come and answer some specific questions during Health Committee, and he's been delayed and has patients waiting. So if you don't mind, I would allow him to field your questions and then continue my report. Dr. Burkhart?
Welcome, Dr. Burkhart. I'm the one that requested this report, and I hope you'll just give us a general overview of what we offer. And I was specifically wanting to know when a provider in an outlying clinic sends in a referral, how long is the waiting list, how big is the backlog, and the different types of hearing aids that we offer, and if they need a second hearing aid, how much do we charge them if they want it, and just kind of give us an overview of what you do.
The wait for an adult hearing evaluation is approximately 5 months. It's down from 8 months when I first started. For a pediatric evaluation is about 2 months. We do have walk-in times every day for patients that already have hearing aids. Our distribution policy for hearing aids right now, if they're deemed to be a hearing aid candidate, Cherokee Nation provides one hearing aid. The cost ranges from $275 to $400. That's our government contract rate. We typically fit the $275 one just to manage costs. The patient has the option of buying a second hearing aid, and then they just, usually the $275 one, they just cover the cost of it. A lot of patients don't order the second hearing aid, which is actually a problem. It's somewhat like wearing eyeglasses with one lens, because your brain uses signals from both sides, and it helps a lot. Also, if we could get a little higher technology hearing aid, there's a good one for $365. That would also prove a benefit. But 2 basic technology hearing aids would be better than 1 high-end hearing aid. We fit all the different styles. It really depends on the severity of the hearing loss, patient preference, some dexterity issues if they're an elderly patient, that type of thing. But yes?
Thank you, Madam Chairwoman. I don't have hearing aids, so maybe I missed something. We not because I need them, that I know of.
We can see in 5 months.
Yeah, and that's encouraging too. But they're gonna wait 5 months, and I thought we sent them out the door with the first set, and there was a backup set at a certain cost. But what I heard you just say is we send them out the door with 1 ear and expect them to pay for the second ear.
That's correct.
That's right.
That's the policy. Now,
Why?
if
Is this some
That's what the
IHS
bu-
inheritance?
No,
Or what's-
well,
I
yeah,
mean,
that's what the policy was when I started. That's what the budget allows for. We actually ran out of funding this last year, fitting mainly $275 hearing aids for 1 year.
Okay, let's just assume that the world was ran by not money, but common sense or some form of something. And no chuckling from the back from the bureaucrats, I saw that. So, if it wasn't about money, but good use of resources and proper care of a patient, shouldn't you send people out the door with a set, a
Yes.
left and a right ear?
If they have hearing loss in both ears, yes. Bilateral hearing aid fitting, and preferably a little higher technology, which would be about $365 per hearing aid.
Okay, so there's an opportunity to upgrade technology, but if, let's just say I had hearing loss in the left ear, in terms of care and proper use of resources and caring for a patient, money wasn't the issue, it was just about making the right decision. If my hearing loss is only in my left ear, do I only get a left ear, should I only get one, or do I get both?
No, you just would need one.
We
If
just
you have
need one.
normal hearing in the right ear.
This is cases where they have hearing loss in both ears, and we only send them out the door with one ear.
Correct, unless they choose to purchase the second one, which some do. These hearing aids would cost $2,000 to $4,000 for one hearing aid if you had to buy it on your own in the private sector.
Oh, no, I mean, I still think I'm grateful for anything we can do, but this is still not what I expected. I'm just a little lost. Okay, thank you.
Yeah,
I
it would
just
be,
wanted to
it
clarify.
would be ideal.
Understood
I
this
would
correctly.
love if we could offer 2 hearing aids.
Okay. I really appreciate your time being here today. Sorry for the delay. Thank you, Madam Chairwoman.
We have a comment from Councilor Hart.
How old is that policy that you're speaking from? Connie, do you know, or Dr. Graham?
I think it went back to Doug Marshall, or was that David Marshall, excuse me.
How long ago was that?
That was
Oh, absolutely.
early 2000s, at least. I know it was before the previous audiologist, and he started in about 4 or 5 years ago.
Some of you council members approved it, though, it sounds like.
I didn't.
And some of the other tribes
I was
do offer
approving
2
a
hearing
set.
aids.
Okay.
Well, the reason I asked for this is so we could bring it forward and think about it and be more knowledgeable about what's going on. So we've got several other people here wanting questions and comments, so.
Thank you, Madam Chair.
Connie?
Clearly, the policy is something we can certainly look at, but unfortunately, it does get down to how much money's in the bank. You can only, I mean, when we're adding the number of patients, and I'll give you some statistics in a little bit, every month, it makes sense that we have to make the dollar go further. The number of patients being seen is going up, but the funding is not. But I do appreciate you being here, Dr. Burkhardt.
Wait, I'm not.
We've got several more questions here lined up. Councilwoman Taylor?
Yes, I'm concerned about the pediatrics. Are they under the same, they get one hearing aid?
No, thanks for
Oh,
that.
good.
If you're a minor, you get 2 hearing aids.
Okay, because I'm worried about speech problems
Right.
and all kinds of things. Okay, could you also tell me, you gave a range of $275 to $500. What percentage of patients would you say either choose to upgrade for better hearing or choose to purchase that second hearing aid if they have loss in both ears?
I would say 25% choose the second hearing aid,
Okay.
and not a whole lot upgrade. I would say 90-some% we fit the 275 model
For 1 ear.
for 1 ear.
Okay, and then follow-up care. I know that it can be hard to get that right. So are you seeing them through until they have good hearing in 1 ear?
What we're doing with the follow-up is the walk-in times. Monday through Friday, we have a morning time and an afternoon time. And then we have them. It would be ideal if we could reschedule them 2 months and then 4 months out, but that's just not feasible with the numbers we see.
So you're relying on the patient
To
to
do-
be diligent with their own care?
With the walk-in, correct.
Okay, all righty, thank you. Thank you, Speaker.
Thank you.
Chairwoman.
Next, Speaker Jordan?
What is your budget for the year for hearing aids?
I would have to defer to the finance department, but what I've been told, I don't know how accurate this is 120,000.
And how
And I
many,
believe that also covers our supplies. So not just, and we also have to cover hearing aid repairs, because the hearing aids have 2-year warranty, but after a 2-year warranty, then we need to repair them. That's another point. Every 4 years, they're eligible for a new hearing aid through Cherokee Nation.
how many patients are you expecting to need to serve?
We do 30 hearing aid fittings a month. That's just hearing aid fittings. We're averaging about 200 patients a month.
And what's the percentage that need both hearing aids?
Well, 30 a month, roughly, and of those, I would say 28 or 29 a month are going to need 2 hearing aids. It's rare that a person only needs 1.
So how much more money are you needing so that we get them a set when they come in?
Well, if we gave them a set and we covered everything and we did the 365 a month ones, it'd be about 300,000.
Okay. So you've got 120 budgeted, but you think you need 300,000. I mean, that's what we're talking about, because it does take money. So what we're laying out here today to the council is you need another 180,000 yearly
Correct.
for your program to work properly.
Correct.
Okay. Folks, there's your answer. We need to find 180,000 because I don't want to turn anyone away with 1 hearing aid. That doesn't make sense. We're all going to be there someday. I think I'm already starting. So,
And to a lot of people, $275 is a fortune, so.
well, I seriously think that we need to find the money. We need to find the money and make it work. I did not realize, and I'm sure that's why Madam Chair had this gentleman come and talk to us today. I don't want people going out with 1 hearing aid if they need 2. I don't want people's teeth pulled and we not give them new dentures. Quality of life is very important, and that's what we're here for, to provide quality of life to our older folks. And maybe we are providing a set for a child, but I want to take care of our elders too, because that's the other end of this issue. So I would suggest that we put this on next month's budget and finance, and we put our accountant to work, and we find $180,000. And I don't know if I need to put that in the form of a motion.
We've got several other people
Okay.
wanting to comment, and then we'll come back to you, okay? Council Lady Victoria Vasquez.
She answered, she
Sure,
got
oh,
the
okay.
question that I was going to ask.
Councilor Thornton?
Yes, we're talking about this hearing aid program, and what budget is this hearing aid program coming out of?
The audiology department's budget is all I know.
Is it federal money?
I've been told it is.
But none of yours has come out of the 5% Cherokee Nation Health Services funding distribution then. Because I don't see anything on here where any of that 5% has went to Hastings. Is that right?
We use the 5% for any of those. Through the BART program.
Then it didn't come out of it, 5%. Why couldn't we look at that 5% to bring that out
We
there?
can.
I see that there's not any Redbird or Stillwell or Muskogee or anything on this 5% funding, hadn't been forever. And that 5% just passed, in 2011, didn't it? I mean, it hadn't been there all that time, because I know it was shot down by the previous administration in '08. We couldn't get 5% added on. So I think we need to look at that 5% and see if we can't pull some funding out of there and see what's left in there.
Very good. Good idea.
Instead of this just showing on the 5% distribution, instead of Veneta, Claiborne, Tulsa, Catoosa, why don't, that's 75, 61, why don't we have an amount there that's been spent there? I'd like to see that. Can you do that for next month?
Yeah.
Okay, thank you very much.
Counselor Lay, you're next.
I think Councilor Thornton caught my question about where this original funding came from. And the 5% really, I think we went through this a couple of months ago, it's spent mostly at Hastings. So I'm willing to look at it, but I'm wondering if there's any money there. Thank you.
Counselor Baker?
Yes. Of the people that you see, how many of them live outside that you cannot provide hearing aids for?
We provide hearing aids, since it's federal funding, or that's what I was told, that we provide anyone that needs hearing aids, the one. Doesn't matter if they live in the 14-county area or not.
Okay, thank you.
Do we have any other questions or comments overall? Yes.
I just have a comment about the funding. You know, when we was doing the budgets, you know, there's a lot of programs that carry over millions of dollars, and a lot of jobs they had in their budget that wasn't hired. So maybe an idea to maybe locate some extra funding. That's all. Thank you, Chair.
Well, Counselor Kara Cullen-Watts?
Thank you, Madam Chairwoman. So, just to follow up, I think, to what the chairwoman had asked, we're gonna get a financial breakdown and report about the 5% with respect to hearing aids, is that correct?
Yes.
Okay, and that'll be in writing, and it'll be to us by email prior to the meeting and not just the day of or the day before?
We will make every effort to make that happen.
Much appreciated. Thank you very much, thank you.
Madam Speaker, that you have a motion you'd like to make?
Yes, I have a motion, and then I also have a suggestion before I make the motion. Back when I first got on the council, I asked Mr. Carson, who was in charge of CMB at that time, to do a study on what it would take for us to make our own hearing aids and our own eyeglasses. I would like for you all to get a copy of that study, so that we might want to take another look at bringing this in as our own, and add teeth to it. Teeth, eye, and hearing aids. Those are basic services that we need to take care of our people with. And we weren't gonna make money, but he had it figured where we weren't gonna lose money either. And I can think of no better program than to serve our people and still break even. So this may be time to, I couldn't get anybody interested at the time, but maybe we can get them interested now. You know, we're 4 or 5 years down the road, maybe we can get them interested now. And I would like to make a motion that we carry this over as an agenda item on our next health.
Second.
Would it be better, I probably need to ask this, would it be, well, it would be better to go back into health again as an actual agenda item, and then if we can find the money.
Next month?
Yes,
Okay.
next month. I would like to make a motion that we make this an agenda item until we get this issue resolved.
So
All in favor of making this an agenda item for next meeting in health, let it be known by saying aye.
Aye.
All opposed? Okay, we'll make an agenda item for next month. And I have one additional comment. I want to thank you, Dr. Burkhart, for taking time out. Connie, Ms. Davis told me that you had patients scheduled, and I asked, you know, maybe you could postpone it or work us in somehow. And we've delayed you quite a bit, but I think it's well worth it in the long run. And I want to say, when I first came on the council, I remember Councilor Jordan saying, you know, we got to take care of our elders. If they just want to sit on the front porch, we want to make sure they've got some good eyeglasses and some dentures so they can enjoy their food. And if they can't do anything but sit in their rocking chair, they can hear the birds sing. So I think this is well worth the time and effort for you to come over and give us this report today, because it's something I was very interested in.
My pleasure.
Thank you. Thank you, Connie, for getting him over here.
Happy to do it. In the month of October, I'll give you some statistical reports. Wilma P. Mankiller saw 11,578 patients. Redbird Smith, 11,194. Salina, 9,077. Jay, 7,928. Nowata, 4,852. Muskogee, 16,180. Bartlesville, 2,248. Bonita, 5,953. The Gadoogie Employee Health Clinic saw 530, and Hastings Hospital saw 33,488. I thought it was worth highlighting that the Salina Clinic, the Bartlesville Clinic, and the Sam Hyder Health Clinic exceeded their budget significantly, anywhere from $200,000 to $350,000. So that shows that we're making progress and improving our billing and collections. And, you know, one good month of that will easily cover a budget adjustment to cover those hearing aids. So we need to continue those efforts. Construction is going well. I think we're 65% complete on the plans for Wilma P. Mankiller. We began the meetings for the hospital. We're making progress there. Three Rivers reports that they created 422 new charts. That's 422 new patients in the month of October. Bonita, 307. That little clinic, what was a little clinic and now a big one, is growing by leaps and bounds. What else? Emergency department at Hastings, you hear me talk about their left without being seen rate. Every month, they saw 5,507 patients, and their left without being seen rate has been 7%. It seems like they give the same number every month, but they've got that down to 4%. So that's a good job by the providers and support staff working there. The admission rate still is not what we'd like it to be. It was 6%. Our goal is 12%. And the average length of stay in the emergency room was 148 minutes. The goal is 141. We performed 413 surgical procedures in the month of October. The dental clinic saw 1,177 new patients. 657 emergencies were seen. So I want to commend both of those efforts on access. Another thing I wanted to mention was I got an email just before this meeting, and it kind of goes back to your previous committee on the Affordable Care Act, and we got some early estimates on the numbers who would be eligible for extended health coverage, and that number was 446,000 in the state of Oklahoma. They didn't specify the number of Cherokees or Native Americans. And to date, for the month of October, 1,673 had actually enrolled in a new qualified health plan. Jack Brown has 21 patients, and they have 21 waiting. We can't get into that new center fast enough. And I have some specific reports that you also requested from the dental department and from the recruitment office. And so if you don't mind, I would like to ask Dr. Steve Jones to come up with his report, and then Kathy Kilpatrick from our recruitment department will follow, and I'll take care of any questions after that.
I think specifically, one of the questions that was asked was about our vacancies for dental positions. So I prepared you a handout that has a accounting of all the changes in dental positions that have occurred since I've been here anyway.
Dr. Jones, does it include feedback from their exit interviews and such? Does everybody get an exit interview?
It depends on how and when they leave. Some of them are, if you'll go to the last page on the summary, it'll give you a summary of when they left, and if they were IHS officers or if they were private hires that left. We have a total of 7, and of those, I believe, sheet out, try and look at it. 3 of them were tribal hires that left for private practice. One of those was prior to our compensation adjustments that we did, and the rest of them were after that, so. And then of the 4 IHS officers, 2 left for family reasons, and 1 left for a promotion, and then we had 1 that left because of the accountability that was being put in place. It's a little more specifics, but I've been asked not to do that unless we go into executive session.
Can I ask other questions around the
Yes,
dental
ma'am, go
program?
right ahead.
Do we still have a dental residency program?
No, we do not, and it's documented there in the front page of the changes that occurred. Some decisions were made based on finances and based on access to our patients. It was requiring a lot of time for our specialists to come out and work in, and it was not open to tribal applicants. It was only open to IHS applicants. So as a result, it wasn't very feasible for us to continue to do that. When they compacted, my understanding is when Hastings was compacted, the money for the residency was not given to Cherokee Nation, so we were funding that specifically on our own without any help from IHS.
Okay, if somebody goes to the ER at Hastings and needs a dentist, do we call in dentist for after-hour emergency care?
We have, our care is open 7-6. There aren't any other ERs around that I know of that have dental coverage. We do have an oral surgeon that is available, and he's been gracious enough to answer the phone and take call, even though he's one person. As far as what you see in a ER, there are life-threatening dental emergencies aren't handled by a dentist, typically, usually by an oral maxillofacial surgeon. So we've got a plan to try to get another oral surgeon on place. If that happens, then we'll be able to do call routinely. But right now, you can't stretch one guy 365 days a year.
Okay, and I read somewhere about crowns in the report, and we've talked about this before, so, we are or we are not providing crowns?
Not at this time.
There's I thought I read in the report that we have provided crowns.
In the past, they were. Not at this time.
Well, it
And I sent out
appears to
an
be
email to
correct.
everybody, detailing that program and showing the cost analysis on that program. And we can do it a lot cheaper, and we've got some programs in place right now. We're doing some negotiating with some labs. They're coming in and looking at our business, see what they can do for us. I think in that cost analysis, it was costing somewhere around $500 a crown. We think we can do it for about $89. So if we can get those machines sold, which I've got one of them sold right now, the other company's going to take it back. And if we can get the other 2 sold, we'll take that money and turn it into lab fees so we can provide those services. And they'll be all over 14 counties, not just in 2 areas.
Okay, how do you plan to do outreach to Claremore Indian Hospital to serve Cherokees that are primary carers at Claremore Indian Hospital?
We have no control over their dental clinic there,
So educational outreach, what would be the plan?
we've developed a community dentistry department, and you've seen us at all your community
Right.
health meetings. So we're working on getting more educational materials out there.
So you're gonna provide those to George, you said he'd put them out? That's what I heard in his report, right?
We'd be glad to provide those. We've actually looked at some referral processes back and forth with their specialists, but we haven't been able to get those in place very well.
Okay, and let me ask, maybe I didn't, did you answer that yes, Human Resources provides an exit interview when people leave?
That I'm not aware of if they do. It's usually, in our case, for example, with the commissioned officers, the one that transfer, we usually get 30 or 60-day notice that they will be transferring. And we're basically trying to clean up their cases to get them finished so that they can exit and move to the next location.
Okay. Thank you, Dr. Jones. Look forward to reading your report. I'll have more questions, I'm sure. Thank you, Madam Chairwoman.
Thank you.
I have
Anyone
one
else
other
have
thing
any-
I want to pass out and
Okay.
just for your information. It's a summary of some of the accomplishments that we've done in the last fiscal year. So I don't know if that always gets in the reports, but I don't know if it always makes it to you or not. And if you have questions on any of that, you can contact me through email, obviously, or phone calls, anything that you have questions on, I'd be glad to answer at any time.
I think Councilor Hargis has got something.
Dr. Jones, I just want to say, I think you're doing a great job. I do appreciate all you're doing. But I have a question on Stillwell. How many dentists do we have there?
3. We currently have 6 because Salisaw is displaced right now. So we have the 3 dentists that will be at Salisaw, and we have the 3 dentists that will be there permanently.
How many patients does that department see on average? Do you,
I'd have to get that for you. I don't have it broke down on average, and because of the snow and the time off, I haven't got my reports for this month yet, so we have a little delay.
The second biggest complaint I get from Mankiller is the trying to get an appointment in the dentistry. And is there any way that we can change that? Because they say if you call, they tell you to call on a certain day between whatever time, and most of those people that parents or whatever are getting kids to school or getting to work, and it's kind of impossible to make a call at that time. Is there any way we can change that?
We did change it a little bit. Before, they were picking a day, one day a month, that they did all the appointments for the next month, and it wasn't working very well.
Right.
And so now we've made it where every dentist has 4 appointments per day for new patients. So we're giving out those appointments 30 days in advance. So every day they have 12 appointments to give away 30 days in advance. So that's the way that they're filling it now. Now, I did find out that Stillwell was taking some of their emergency appointments and filling in their exam appointments. So they were a little bit confused on how that process works. So it should get better. We've corrected that now because the emergency patients need to go through the same process that everybody else does and make the phone call. So it should get a little better. We just found out that that's what some of the staff was doing. So it should open up access a little bit better.
All right, thank
Okay.
you. Thank you, Madam Chair.
Any other comments?
Yes.
Speaker Gordon.
This was not a complaint, but it was some information that was given to me. I don't know where they had read it, but we had people saying that your folks were just leaving left and right, and what I'm seeing here is your dentist, it appears to me, one returned back to the state where they were from to care for their mother for a stroke. Well, no amount of money is going to keep them here if they need to go home and take care of their ailing parent. Here's another one that purchased private practice with her brother. She probably planned to do that the whole time she was in school. I mean, you're not going to be able to keep someone that has a plan for her own future. You got another one, the husband got a job in Texas. Well, obviously she's not going to stay with us if her husband's in Texas. I don't know, that might not be a bad idea for some couples, but most of them would go with their spouse. Then you've got one that resigned to enter private practice, but both of it was on, it appeared to be something that they had planned to do. You got a transfer to Alaska for promotion of an IHS officer. I'm not seeing what's going around out in the communities that we're just running dentists off. You can't hold people to a job if they personally can develop themselves in another way or had a plan to develop themselves in another way. All we can try to do is replace them. And it looks like that you've got 3 vacancies.
3 vacancies. We interviewed a gentleman for Veneta. He is in Arizona right now and moving to this area. We're hoping to have him on board after the first of the year. The pediatric dentist, we've got an interview on the 26th of December. Actually, someone that lives in North Carolina that has an Oklahoma license already, so looks very promising, and we're going to interview them. The other position is one that we haven't decided if we're going to fill or not yet. We're trying to increase our hygiene program so that all of our patients get 2 times a year cleaning and exam rather than once. So we may use the money from that position to increase our hygiene position in Muskogee.
Well, and the second comment I got was, well, you have all these chairs and you just have this many doctors. I think the world needs to realize that if you've got a dentist, he's going to be going to multiple chairs at different times. You're either getting somebody done, you're getting a couple ready, or you may be using some of the chairs for cleaning. So it's not, every chair is not going to have a dentist standing behind them.
Right.
But maybe every 5 chairs might have one dentist standing behind them or something. This is, you know, you hear all these rumors out in the community, and this is good information that we need to know because we can counteract those rumors. It does not appear from what I'm seeing here in your report that we had one person that did not live up to expectations of the job.
Right.
1 out of, looks like 7.
That's
And
correct.
apparently they were asked to see so many patients and they thought that was more than they wanted to see.
Yeah, we had approximately 85 5-hour blocks of OR time set aside for that person. And we had 40, I think I gave the number there, 47 children that got seen in 85 5-hour blocks. So not very
So they wanted a
productive.
full-time check for half-time work.
Right.
I would love that. I'm very,
we've asked, you know,
I'm glad that you gave us this report because it will give us information that we can use out in the public.
Yeah, and just to give you an idea, in my private practice, we had 12 chairs. 2 dentists and 2 hygienists ran 12 chairs. So, and we're not basing our model on that. We're actually toning that down a little bit to where it's going to be 3 dentists and 2 hygienists for 12 chairs. So we're still getting closer to that model and having some accountability, but we're asking them to do a little more than what they've been done in the past.
Well, I've been going to the same dentist for years, and he built a new office and doubled the number of chairs, but it's still the same 2 dentists. So I fully realize when you go past 24 rooms and you know you only have 2 dentists there, that they're planning, they've got a staff that's doing good planning for them. And I hope that's what we're leading to. I'm glad to see some of the improvements that you're
We're getting there. We're still a little ways away, but we're getting there.
Thank you.
Okay.
Councilor Byrd has a comment.
Go ahead. I'll go ahead.
Thank you, Madam Chair. Dr. Jones, thank you for coming to the community meeting. You were very helpful. And I do have a question about Benita. If we get that new hire in January, will we still have Dr. Phillips? So will we have 2
We'll
dentists?
have Dr. Phillips, Dr. Henry, and the new hire.
So we'll have 3.
And my understanding is in June, we have funding for the next dentist. So we'll start recruiting and looking at the new classes coming out and seeing who has scholarship payback. Some of these people that leave have scholarship payback, so they'll complete their 4 years and then they have plans to go somewhere else. I was one of those people. Came to Cherokee Nation for 4 years, then went to private practice. So it's just something that's the nature of the beast when you have scholarship payback. Everybody's got to try it. You know, until they try it, they don't know whether or not it fits them or not.
And how many hygienists do we have that work at
You have 2 right now, and our plans are to increase it by another position.
Thank you.
Dr. Jones, I just want to commend you on coming to the community meetings. I've seen you at several, you and your staff, and I want to thank you for that. Also, I want to commend you on getting away from that old IHS model of serving our people. I mean, you've gone out there and got innovative and made some changes, and if these people don't want to work with us, and they weren't qualified to work with us in the first place. But now you have a plan in place, and just thank you for this sterile report. We haven't had those in years past. Thank you.
Yes, Councilor Buzzer.
Dr. Jones, when do you think, what kind of a time frame do you think you may have something in place for Crown? Contracting over?
It depends on, I'm working with procurement and how to get rid of the machines that we already have. We had a buyer and that kind of fell through, and trying to figure out exactly how we get those out of our system and into somebody's hands and actually take the money. And the one machine is new enough that the company's going to actually give us the money back for the machine. So that money, once it hits, we should be able to start relatively soon. Because we'll divvy it up between the other clinics and get a contract in place with a lab that'll give us, the goal is to get, we have enough buying power, we can get the price down. That's the thing. And then it's eligible for everybody under a certain criteria. Not everybody will get crowns just because they want a new crown. It has to fit a certain criteria, and we have to make sure that we follow that in order not to break the bank. You know, there's only, we've got to stay within those parameters of what the criteria is going to be. And I've asked I've got a work group of directors that is putting together a policy that'll allow us all to follow it. And it'll limit the number that person can have a year so that, you know, that we don't overextend ourselves and get to a position where I come up here and ask for more money.
Doctor? Thank you.
Any other questions for Dr. Jones? Just keep up the marvelous work, is what I say.
All right, thank you.
Hello, I'm Kathy Kilpatrick. I think a lot of you know me already. I've been around for a while here at Health, and so I have a staff of 4 now doing recruitment and retention. And let me get by the microphone. Can you hear me? Anyway, I think Ms. Davis and Dr. Montgomery said, can you give them an update? We've been slow because I think everything kind of slows down around Christmas and January. People are not really looking. They're trying to get through the holidays. But we put together this, we always put together a report for Health Committee, and down at the bottom is a calculation of total funded physician and mid-levels. And we're down total 9. And at the top where it says total providers, that's everybody that's on employment agreement. So I think one of your concerns is physicians and people to do direct, primary care. And it just gets harder and harder and harder, because doctors can go anywhere they want to go and probably name their price. So they have to want to be here. And then there's some considerations. It's family, then they ask, well, how are the schools? Can we get private schools? They want their children to go to private schools. And then another obstacle that we look into, it's like, well, can my spouse find a job around here? So it's always a lot of factors whether they can come here or not. So anyway, we're working hard, and I encourage you, if you run across a good doctor, send them our way. Our credentialing committee is very strict. We don't take providers with issues. Our standards are really high, and so a lot of times I have to tell the provider, I'm sorry, they won't pass you, and it's one of those things that we do have good quality doctors.
And you may not be able to answer this, and you might too. How many behavioral health people do we have? Molly and George might can answer that for me, or maybe you don't.
Well,
I'm talking about Claremore Hospital and then Hastings Hospital and also the clinics.
I'm not sure on behavioral health. We recruit the psychologist and the psychiatrist, and as far as behavioral health, there's probably a big shortage.
Okay. Connie, do you know?
I would say roughly
20? 40?
total staff.
Does that include Claremore, too, you think, Claremore? Is that right? Okay. I realize I had that.
We are excited that we've got a psychiatrist coming out of school be able to work next September, and he has signed on to come join us. Our radiologist will be here in August. We're having an on-site radiologist that's Cherokee Nation hired. So it's not a easy task, and we chase every lead. We've had 2 doctors that we interviewed that looked very promising. Now they don't return our phone calls, so, you know, they probably got another option. They just don't want to tell us no.
Counselor.
Thank you, Madam Chair. Good to see you, Kathy. Merry Christmas. So in follow-up to Councilman Buzzard's question, how many are we short in terms of psychiatrists and psychologists in behavioral health?
We've been short, you know, since Dr. Redcorn left, short one psychiatrist. We actually recruited a psychiatrist that's finishing up, that is actually from the Oklahoma area. Psychologist, they have the new project that's the HERO project, that we're having to look for licensed social workers and psychologists to develop, to get them hired to have teams. So that's real competitive, and a shortage of social workers that want to come to Talakai. I commend ever who developed the directed studies program. We're going to reap some benefits pretty soon. We'll have 2 physicians come out to come and work at Cherokee Nation, and we don't have to compete with IHS, and they could go anywhere, you know, tribal or IHS. But we have two physicians coming out, and it would be very encouraging to have a lot more for primary care.
Kathy, could you give us a written report on what we're short in behavioral health and where? Because I don't necessarily, when I pick up this, I don't see that part.
Yes, we could give you, what they're really short is the HERO project, getting that staffed, where they're short.
What's a HERO project? Could you tell us about that? I'm not sure I understand what you're talking about.
The HERO project, is in a nutshell, is a grant that we were awarded, and it provides behavioral health services to children. We are just now in the very early phases of even hiring and placing those employees. And to be clear, Kathy is responsible for recruiting the professionals in the behavioral health department. She doesn't do all of them, so that will be a joint effort by her office and mine to get you a total count like you guys are asking.
Okay,
This is good.
thank you. Thank you, Madam
Thank you,
Chair.
Kathy.
Thank you. Counselor Garvin?
Yes. At the bottom,
Hang on a minute.
Maybe
Lead, yeah.
this handout you passed out, down at the bottom, bottom line, says total funded positions and mid-level. What does that mean?
Mid-level's a physician assistant, a nurse practitioner, that we call them mid-levels.
What kind of education do they have?
It's usually like with a nurse practitioner, they're usually, they're a nurse, and then they go back into the master's program, and then they're advanced practice registered nurse. And the physician assistant, I think it's 3 years.
Thank you, Madam Chair.
Kathy, I have a question for you. When you're recruiting these physicians in mid-levels, do you take into consideration their command of the English language? Because I've recently had a lot of complaints about a new physician on staff at Redbird, that especially the elderly are having a very hard time understanding and communicating with this person.
I would think that that person here, they have it, Salisol's probably a locum, Salisol's been short 2 physicians. And I did, when we assumed Hastings, there was some physicians there that I had to convert over to contract. I couldn't understand. It was really having some anxiety. So if I can't understand them, it's like I don't get excited about it, because I think it's a big barrier if you can't communicate with your doctor.
And when she says locums, they're not hires, they're not our employees, they're just a temporary placement.
Well, I really have some issues about Redbird being vacant doctors for so long when I have recommended people that have worked there for 20 years in the past and they can't get their foot in the door and they would like to come back. And they sure speak Oklahoma English and they were excellent physicians for 20 years. So I think we have some problems that I'd like to sit down and visit with you about.
For Salsa, we do have 2 new physicians coming out that are looking at the facility, scheduled visits, so that's promising. As far as the one that you were talking about, I'll leave that up to Dr. Montgomery. Thank you.
Ms. Davis, I have another question. How close are we to having a grand opening for the original Redbird Clinic?
Cherokee Nation businesses and Cherokee Nation CNI are coordinating all of those ground openings, and I have not heard a date.
Well,
for
a
that.
soft opening. That's
I
just
will
want to
have
know
to-
when it's going to be ready. I go up there all the time. It's getting very, very close. I know that.
I will email Amanda Clinton after this and try to hold her down to some more specifics. We're anxious to do it as well. The plan was to maybe do one a month after the first of the year.
We're anxious, very anxious up there.
I understand.
Councilor Garvin.
Thank you, Madam Chair. Marty, I think you've been trying to work out an arrangement with the dermatologist, Three Rivers. How's
Yes.
that going?
It's going well. Dr. Montgomery has had several meetings with several people from OU to shore up that service. And as far as I know, we've got that going again.
So it should come into being soon.
Should be.
Is the doctor from Tulsa?
I believe so, yes.
Thank you, Madam Chair.
Yes, Councilor Watts.
Thank you. Welcome back up to the podium. So on the 5% dividend on the hearing aids, dentures, prosthetics and stuff, will you be working soon with George Vallier to put out materials for outreach for our Cherokee citizens? at
We will
Claremore?
sure try.
Will you report back to me when that's done over the next week or 2?
No, I probably can't do that, but we will, it's gonna take some planning because it's so complicated. Early on, when I first started this job, I thought I was gonna solve all the contract health issues, and how foolish of me, because it's so complicated. But, you know, we will go back and see what we can do to try and make a good effort to communicate to all of our citizens how to access CHS for hearing aids, for dental, and make it's hard enough for us to understand. To do a better job of that.
So could you start by putting those trifold brochures I've already seen you develop
Yes.
and sending him a couple
Certainly.
100 copies before the end of the year?
Yeah,
so
we
you
can
put
send
them
him
out?
that attachment today. We can do that.
I don't know that he has the budget at IHS to even print it, so you may have to print it for him. He's shaking his head no, so if you can print it.
All right, Brett's
Okay.
gonna send them home with him today.
Okay, very good.
Thank you, Brett.
Then on the $100 million health build out, what, do we have a finalization on what the staffing needs? Do we have a chart on what the additional staffing needs will be, as well as like what are additional
Counselor Watts.
services?
Excuse me. I'm going to have to go see Dr. Burkhart, or you're going to have to talk a little louder. I can't hear you, or maybe the mic's not on. I don't know. I'm having a hard time hearing up here what you're saying.
Okay, I'm asking her on the $100 million health build out, does she have a chart of additional staffing and services that are gonna be provided? And do we have an idea on how much IHS is gonna reimburse us, if anything, or provide for operating costs, and what the additional operating cost will be?
There were several questions there, and I'll try the best to remember everything.
Okay.
We have a preliminary plan of the anticipated needed staff that we will phase in over time. We do have a list of services with each clinic that will be added or expanded. What else?
And then, do we have any idea on like what IHS, what's the differential in operating cost from our existing clinics to the new, and will IHS assist us with any of that, or is that gonna be totally out of our budget?
We do have those costs and that are predicted, and we don't know about assistance from
Okay,
IHS.
so can you share those plans with us, or the preliminaries, and
Yes.
see. And then the one last question I had for health, because before that, we don't have anything on money impact. That's what you put in your report about the 90-day prescription impact. We don't have that yet, even with this.
Yeah, I sent a document around, of course, that's 1 month's data. Dr. Montgomery can help field any questions, but basically, so far, so good. It hasn't had a tremendous impact, but we didn't anticipate the first month to have a tremendous impact. We expect it to be January, February, and March, when we're well into the refills, people coming back for that 90-day to
So
see.
it was about $400,000 was the only increase we saw, and that could have been just additional prescriptions. I was trying to figure out how to measure what I was measuring for comparative.
I believe so. Jeff sent me that literally as we were walking out the door, and I didn't get to study it real well.
Trying
so.
to read it and make sense of it, so it's nice. So one last question, on page 17, you're looking at cancer, and it looks like we've gotten a lot of cancer folks in your report. Are we looking at clusters? Are we doing any kind of CDC type analysis or asking the CDC to do analysis for us? I continue to hear about just bizarre cancers, and what it seems, if I'm one person in the community and I hear about rare cancers or young people and they're all in the same area and they're getting, it just seems odd. Do we do any kind of CDC type function with the cancer registry in order to see if there are any clusters or things that we may need to be looking for as a government?
Our main focus is breast and cervical cancer, of course, and I'm not really familiar with anything else that are
So
more
we don't
directed
register
studies.
anybody else? Okay.
Well, I'm not saying that.
This Sears registry is very unique. Dr. Khan is responsible for that. I don't know if you've met.
Oh, I know, SoHealth.
This
Yep.
is a very, very all-inclusive native cancer registry. So it's going to include common cancers, but also your much more unusual cancers. But, and we can get you that report, Councilor White. But we have a breakdown for you by cancer type, native citizens in our area that die from cancer.
Have we ever mapped it?
I mean, geographically, it'll happen by county. It's by location, all by diagnosis and by location.
So it doesn't go to me outside you could take, where they work, where they live, if we have that, I don't know what detail it goes to, but I'm concerned.
Yes, we get a copy of what we have and do that to you, okay?
Okay, thank you. I appreciate it, thank you, Dr. Montgomery. Thank you, Connie. Thank you, Madam Chairwoman.
Thank you. I've got one last comment. I want to thank everybody in the health department, and I want to thank all the council people here, because we are tasked with seeing that our people have the finest health care. I want them to feel like that they're getting just what they need here as if they were at the Mayo Clinic. And our job is to see that you have the funds to do it with. And so we task you with providing the very finest. And we don't mean to be hard or disgruntled at any of you. It's not personal. We're just trying to raise a higher standard, and I can see on the last 6 years the improvement that we have made in healthcare. It's just gigantic. So I'm well pleased. That's all I have to say. Councilor Busby.
And I just want to echo what the chair lady said, Connie, and the increase of $300 and some thousand at Sam Howard Clinic is tremendous. Apparently, you talked to somebody about billing. I want to compliment Dr. Jones about his billing. So that's what it takes. We want people to work 8 hours a day, and that's what they're supposed to do. And that's what we expect them to do, and I'm sure you do too. So I see some improvements. I want to thank you for it.
We hope to report the new provider scorecards for the primary care providers, some results from that. I think you're going to see a pretty impressive impact
Yes,
from setting some quality expectations along with the productivity. And, it's not always a popular thing to tell a provider they need to see more or do more. And so we've included all medical directors with the decisions and how they will be measured and setting our expectations so that we do provide the quality, but still, part of quality is getting in. So
Thank you.
we appreciate the support of the council and the chief, of course.
We thank you for your time and your patience and your dedication. So If anyone else has any other thing to say, well, if not, well, we thank you.
Thank you.
We have no old business pending or new business. And an announcement, anyone have an announcement? Our next meeting is scheduled for January the 13th at 1 p.m. in this same facility.
How much time do you have? 5 minutes.
Okay, next one.
Motion we adjourn.
All in favor of adjournment, let it be known by saying aye. Aye. Thanks to everybody. We had a good meeting.